let us start. This gets us to our next topic in general pathology, that is genetics. We are done with the first two main topics, cell injury, inflammation. Next is genetics. Genetics, once you get a hang of it, it is understanding based. Once you get a hang of it, it is much more comfortable and easier to understand and remember. So starting with genetics, as a general rule, or you already know this, the human genome, it has 3.2 billion base pairs. Human genome has 3.2 billion base pairs. It has 3.2 billion base pairs. Out of which the coding region means DNA to RNA, RNA to proteins. This is what we mean by the coding region. DNA to RNA, RNA to proteins is just 1.5%. मतलब पूरे genome का, if the whole genome is 100%, पूरे genome का only 1.5% is the coding region. So I can safely say that the remaining 98.5% is the non-coding region. I can safely say that the remaining 98.5% is the non-coding region. What do we mean by non-coding? Non-coding means DNA to RNA synthesis has occurred, but RNA to protein synthesis is not taking place. So the remaining 98.5% is the non-coding region. Next point. So can I say that this non-coding region does not have much role in the body? Can I say that? Of course not. Non-coding region, it plays an important role. Non-coding region plays an important role in gene regulation. Please put a star in this. This is important. It plays an important role in gene regulation. That means all your promoters, enhancers, and suppressors are seen in non-coding region. All the promoters, enhancers, and suppressors, everything is present in the non-coding region. It plays an important role in gene regulation. It regulates the genes. So promoters, enhancers, suppressors, everything is in the non-coding region. Next point. This starts us now. Again, let us again have a look at basics only. You again know that 3 nucleotides. How many nucleotides form one amino acid? 3 nucleotides form one amino acid. 3 nucleotides form one amino acid. You know this. You also know that we can divide nucleotides into 2 types. That is purines. We can divide nucleotides into 2 types. That is purines and pyrimidines. We can divide them into purines and pyrimidines. Pyrimidine is a longer word. So there are 3 pyrimidines, that is cut. Cytosine, uracil, thymine. There are 3 pyrimidines versus A and G, adenine and guanosine, which are the purines. You know this from biochemistry also. 3 nucleotides form one amino acid. Nucleotides are of 2 types, purines, pyrimidines. Pyrimidine was a longer word, so cut, CUT. Cytosine, uracil, thymine are the pyrimidines. AG, adenosine and guanine are purines. 3 nucleotides form one amino acid. Next point. So this starts us with our first small topic in genetics, that is point mutations. Point mutation is mutation in a single nucleotide. It is mutation in a single nucleotide. 3 nucleotides form one amino acid. Mutation in a single nucleotide is called as a point mutation. What are the types of point mutations? Starting with the first one, that is a conservative point mutation. Conservative point mutation means point mutation hui, a single nucleotide is altered, point mutation hui, which leads to formation of a new amino acid, leads to formation of a new amino acid which is biochemically similar, to original, which is biochemically similar to original. That is, the biochemical function is conserved. This is a conservative point mutation. Biochemically, it is similar to original. Conservative point mutation. Next is a non-conservative point mutation. Next is a non-conservative point mutation. Non-conservative point mutation means, again, point mutation हुई which leads to formation of a new amino acid, which is biochemically different from original, that means the biochemical function is not conserved. Non-conservative point mutation, biochemically different from original. Next is a silent mutation. Silent mutation means point mutation हुई, a new but no new amino acid is formed. Point mutation हुई but no new amino acid is formed. It is the same original amino acid only. So what is the difference between a conservative point mutation and silent mutation? Conservative point mutation में it was a new amino acid, biochemically similar, whereas silent mutation, point mutation हुई but it is the same original amino acid only. That is the silent mutation. Next is a nonsense mutation. Nonsense mutation, it is so nonsensical in nature that it leads to the formation of nonsense mutation. It is so nonsensical that it leads to the formation of stop codons. Nonsensical है, stop codons बन रहे हैं. You know this. Which are the stop codons? They are UAA, UAG and UGA. It leads to the formation of stop codons. That is nonsense mutation. So point mutation हुई which led to the formation of stop codons UAA, UAG and UGA. The next point mutation is transition. Next is transitions. Transition means a purine being replaced by a purine, or pyrimidine being replaced by a pyrimidine. Purine being replaced by a purine or pyrimidine being replaced by a pyrimidine. Purine कौन से थे? AG. So if A is replaced by G or vice versa, that is transition. Pyrimidine क्या थे? Cut. CT. uracil तो RNA में आता है, DNA में तो CT, so C being replaced by T or vice versa. Point mutation है. There is a mutation in a single nucleotide. Purine by purine or pyrimidine by pyrimidine. That is transition. Versus the next point mutation. That is transversion. Next point mutation is transversions. In transversion, purine is replaced by pyrimidine or vice versa. That is pyrimidine being replaced by purine. Which are the purines? AG, A or G being replaced by C or T, या vice versa. That is transition and transversion. So opposite है. Transition में purine से replace हो रहा था, pyrimidine by pyrimidine only, versus transversion where purine is getting replaced by pyrimidine or vice versa. Next, this gets us to our last point mutation. That is frame shift mutations. Frame shift mutations, they occur because of insertions or deletions. frame shift mutations, they occur because of insertions or deletions. What do we mean by this? Dekho, you very well know that three nucleotides form one amino acid. You know this. Three nucleotides form one amino acid. If there is an insertion, if a nucleotide is inserted in it, if there is an insertion, the whole reading frame is shifted. This is called as frame shift mutation. This is called as frame shift mutation. पूरा रीडिंग फ्रेम शिफ्ट हो गया है. This is a frame shift mutation, occurs because of insertions or deletions. This is a frame shift mutation. So these were the types of point mutations. They were the point mutations: conservative point mutation, non-conservative point mutation. Next, silent mutations: nonsense mutation, transition, transversion, and frame shift mutation. They were the point mutations, mutation in a single nucleotide. Next point. So this is where we start with our main topic, that is genetic diseases. This is where we start with our main topic, that is genetic diseases. First point, starting with genetic diseases, I can divide the genetic diseases into three main categories. That is Mendelian inheritance. I can divide the genetic diseases into three categories. That is Mendelian inheritance. Mendelian inheritance, it can be either autosomal or X-linked. You know that very well. या तो ये autosomal हो सकता है, either it can be autosomal or X-linked in nature. Both autosomal and X-linked can further be either recessive. It can either be recessive or dominant in nature. So first category of genetic diseases is Mendelian inheritance. Autosomal, X-linked, recessive, dominant. तो चार टाइप हो गए: autosomal recessive, autosomal dominant, X-linked recessive, X-linked dominant. Next category of genetic diseases is non-Mendelian inheritance. Next category is non-Mendelian inheritance, which is of three main types. That is genomic imprinting. Non-Mendelian inheritance तीन टाइप का है. It is of three types. That is genomic imprinting, trinucleotide repeats, genomic imprinting. Next, trinucleotide repeats, and mitochondrial inheritance. Trinucleotide repeats and mitochondrial inheritance. This is non-Mendelian inheritance. So non-Mendelian inheritance, it is of three types: genomic imprinting, trinucleotide repeats, and mitochondrial inheritance. Next point. Next, the third category of genetic diseases. Is chromosomal abnormalities. Chromosomal abnormalities, they can either be in number. Chromosomal abnormalities, they can either be in number or structure of chromosomes. They can either be in number or structure of chromosomes. Whatever we have written on this slide, we will do this one by one. This is the topic genetic diseases. So this is your topic genetics. We divided genetics or genetic diseases into three categories: Mendelian inheritance, non-Mendelian, that is genomic imprinting, trinucleotide repeats, and mitochondrial inheritance. Non-Mendelian inheritance and chromosomal abnormalities, which can either be in number or structure of chromosomes. This is genetic diseases. First point, let us start with our first main category. पहले वाली से शुरू करते हैं. That is the first main category, which is all understanding based. That is non-Mendelian inheritance. पहले non-Mendelian से शुरू करते हैं, then we'll go to chromosomal abnormalities and Mendelian. Let us start with non-Mendelian inheritance. Starting with the first non-Mendelian inheritance, that is genomic imprinting. Let us start with the first one. Let us start with the first non-Mendelian inheritance, that is genomic imprinting. But this is all understanding based. You will not be able to rectify this. So concentrate well. Genomic imprinting. What do we mean by this? If you just know that the gene which is getting imprinted, if you just know that the gene which is getting imprinted, the gene which is getting imprinted does not express itself, the gene which is getting imprinted does not express itself, it does not express itself. If you know this, you will know everything about it. जो gene imprint हो रहा है, the gene which is getting imprinted does not express itself. So genomic imprinting, it is of two types. Make a flow chart. We will write everything below this flow chart. It is of two types: maternal imprinting versus paternal imprinting. It is of two types: maternal versus paternal imprinting. First point, the name tells you everything. Maternal imprinting मतलब the gene of the mother is physically present but it does not express itself. जो gene imprint हो रहा है, it does not express itself. So maternal imprinting, mother का gene physically present है but it does not express itself. Versus paternal imprinting, the gene of the father is physically present but it does not express itself. What is the name of the disease with maternal imprinting? It is called as Prader-Willi syndrome. Maternal imprinting called as Prader-Willi syndrome versus paternal imprinting, which is called as Angelman syndrome. Versus paternal imprinting, that is Angelman syndrome. Easy to remember. देखो, P and P साथ में नहीं जाते. P and P do not go together. Maternal imprinting is Prader-Willi, paternal imprinting is Angelman syndrome. P and P do not go together. Next, इसमें हम कौन से क्रोमोसोम की बात कर रहे हैं? Which chromosome are we talking of? We are only and only talking of chromosome 15. Nothing other than that. We are only talking of chromosome 15, and that to the long arm of chromosome 15. PQ, P for petite. Petite is the short arm. Q is the long arm. We are only talking of long arm of chromosome 15. Next point. So let us start first with Prader-Willi syndrome. In Prader-Willi, you very well know that we get one chromosome set from the mother. We get one chromosome from the mother, one from the father. You know this. In Prader-Willi syndrome, chromosome of the mother is physically present, but it does not express itself. Maternal imprinting, physically present है but express नहीं हो रहा. Plus, what will happen to the chromosome of the father? It is getting deleted. Plus paternal deletion. देखो बच्चे, डिजीज तभी होगी जब दोनों क्रोमोसोम का प्रोटीन नहीं बनेगा. डिजीज विल अकर ओनली व्हेन प्रोटीन ऑफ बोथ द क्रोमोसोम्स विल नॉट फॉर्म. Think of it as if we have to do something naughty at home. Both the mother and father should not be there. Mother is there but she is sleeping. Maternal imprinting plus father is not at home. Paternal deletion. That is Prader-Willi. Versus Angelman syndrome, which is paternal imprinting plus maternal deletion. Angelman, which is paternal imprinting plus maternal deletion. So this is the first method of having the disease. First method क्या था? Imprinting plus deletion, which accounts for 70% of the cases. This is the first method of having the disease, which accounts for 70% of the cases. Next, the next method of having the disease, continue the same flow chart. Next method of having the disease is disomy. What do we mean by disomy? First method was imprinting plus deletion, जो 70% था. Second method is disomy. Disomy means both the chromosomes come from same parent. Both the chromosomes come from the same parent. That is disomy. So you tell me, Prader-Willi में कौन सी डाइसोमी होगी? मैटरनल डाइसोमी या पैटर्नल? मदर या फादर? मदर. Maternal disomy. Both the chromosomes, maternal disomy, both the chromosomes came from the mother. Both the chromosomes came from the mother, but they do not express themselves. Maternal disomy. Versus Angelman syndrome, which is paternal disomy. Both the chromosomes came from the father, but they do not express themselves. This is the second method of having the disease, disomy. Next point, clinical features. Continuing the same table, clinical features. Let us start with Prader-Willi. Prader-Willi syndrome, it was maternal imprinting plus paternal deletion. Remember, P and P do not go together. So if mother is sleeping, we sit in front of TV and order food whole day. So it is associated with hyperphagia. If mother is sleeping, remember it like a story, you will never forget it. We sit in front of TV and order food whole day. Hyperphagia. We are not going out to play basketball, so it is associated with hypotonia. Short stature. We are not going out to play basketball. Hypotonia. Short stature. Hypogonadism, and is also associated with mental retardation. This is Prader-Willi syndrome. We sit in front of TV and eat food whole day. So hyperphagia, hypotonia, short stature, hypogonadism, and mental retardation. Versus Angelman syndrome, in which if the father is sleeping, we talk happily on phone whole day. So the classical term that is used is happy puppets. The classical term is happy puppets. What is happy puppets? It is uncontrollable laughter. Happy puppets. It is uncontrollable laughter with ataxic seizures. With ataxic seizures, and is also associated with mental retardation. This is genomic imprinting. You know everything in this. If you just know कि जो gene imprint हो रहा है, the gene which is getting imprinted does not express itself. So it was of two types: maternal imprinting, paternal. Maternal imprinting was Prader-Willi, paternal imprinting is Angelman syndrome. These are the clinical features associated with each. Done, bache. This was your first non-Mendelian inheritance, that is genomic imprinting. Next point. This gets us to our next non-Mendelian inheritance, that is trinucleotide repeats. This gets us to the next non-Mendelian inheritance, that is trinucleotide repeat diseases. And the classical trinucleotide repeat disease is Fragile X syndrome. Let us start with the classical one, that is Fragile X syndrome. Classical trinucleotide repeat disease, Fragile X syndrome. First point, before I go further, which is the most common genetic cause of mental retardation? Answer, bache. Now sometimes in my face-to-face classes, students fall into this trap and they say it as Fragile X. No. Most common genetic cause of mental retardation Down syndrome. Most common genetic cause of mental retardation is Down syndrome. Down syndrome followed by Fragile X syndrome. Most common genetic cause Down syndrome followed by Fragile X. So second most common genetic cause of mental retardation, Fragile X syndrome. Next point, the gene mutations seen in Fragile X, it is associated with FMR1 gene mutation. It is associated with FMR1 gene mutation, which stands for familial mental retardation 1. FMR1, familial mental retardation 1 gene mutation associated with FMR1 gene mutation. Next point, Fragile X syndrome. Which trinucleotides are getting repeated in this? The trinucleotides getting repeated in Fragile X are CGG. Easy to remember. देखो बच्चे, ये second most common genetic cause था mental retardation का. It was the second most common genetic cause of mental retardation. If the patient is mentally retarded, उसको कम ज्ञान है. For the Hindi speaking, कम ज्ञान. Easy to remember. The trinucleotides getting repeated are CGG. What do we mean by this? देखो, normally all of us, we have 30 to 60 repeats. All of us, that is CGG. In this way, it is repeated 30 to 60 times. All of us, we have 30 to 60 repeats. Next, there is a pre-mutated state. Which has 300 to 400 repeats. There is a pre-mutated state which has 300 to 400 repeats. And lastly, there is a mutated state. Which has 3000 to 4000 repeats. There is a mutated state which has 3000 to 4000. So mutation is increasing in multiples of 10. Normally 30 to 60 times CGG इस तरीके से था. Premutated state में 300 से 400 बार था. And mutated state 3000 to 4000 times. This is not important. What is very important is this mutation. When does the mutation increase? The mutation, put a double star. The mutation increases at oogenesis. मतलब, if mother is in the pre-mutated state, her child will be in mutated state. Mutation increases at oogenesis. Oogenesis हुआ तो mutation बढ़ गई. Versus if father is in pre-mutated state, his child will be in pre-mutated state only. Spermatogenesis where mutation does not increase, mutation increases at oogenesis. This principle is called as anticipation. Or Sherman's paradox. This is called as anticipation or Sherman's paradox. What is anticipation or Sherman's paradox? Anticipation or Sherman's paradox. This is increasing severity of the disease. With successive generations. Obviously, क्योंकि oogenesis पे the mutation had increased. So increasing severity of the disease at successive generations is called as anticipation or Sherman's paradox. Why paradox? Because our parents are supposed to protect us. Here, because of oogenesis, the mutation is increasing. So it is paradoxical in nature. Anticipation or Sherman's paradox. Next point. This was trinucleotide repeat disease, Fragile X syndrome. Next, अच्छा एक point और देखते हैं. We are doing Fragile X. The trinucleotides which were getting repeated in Fragile X were CGG. Where are these trinucleotides present? These trinucleotides CGG, they are present in the non-coding region. These trinucleotide repeats, they are taking place or they are present in non-coding region. Versus, put a line on the side, Another trinucleotide repeat disease is Huntington's disease. Another trinucleotide repeat disease is Huntington's disease. Hunter keeps the animal in cages, CHE. So in Huntington's, the trinucleotides getting repeated are CHE. Hunter animal को cage में रखता है CHE, which are getting repeated in the coding region. This is the difference. In Fragile X syndrome, trinucleotides getting repeated was CGG जो नॉन कोडिंग रीजन में थे, वर्सेस हंटिंगटन्स जिसमें कोडिंग रीजन में रिपीट हो रहा है. एंड इन हंटिंगटन्स द म्यूटेशन इंक्रीजेस. In Huntington's, the mutation increases at spermatogenesis. Very important. कोडिंग रीजन में रिपीट था ना बच्चे. जो भी ट्राइन्यूक्लियोटाइड्स कोडिंग रीजन में रिपीट होते हैं उसमें म्यूटेशन इंक्रीजेस एट स्पर्मेटोजेनेसिस. सो नॉन कोडिंग रीजन the mutation increased at oogenesis versus in coding region where the mutation increased at spermatogenesis. Next point. Coming back to Fragile X syndrome. Let us come back to Fragile X. Fragile X, it was a mutation in FMR1G, familial mental retardation 1G, FMR1G. So clinical features associated with Fragile X syndrome. This gets us to the clinical features with Fragile X. First point is obvious that it was the second most common genetic cause of mental retardation. So it is associated with mental retardation. ये तो बहुत obvious था. What you need to remember is, in Fragile X syndrome, everything is large. That is, it is associated with a large forehead. Large jaw is called as macrognathia. It is associated with large jaw, that is macrognathia. Large testis. You tell me, what is large testis called as? Macroorchidism. Large testis, that is macroorchidism. Large testis and large ears. So in Fragile X syndrome, everything is large forehead, large jaw, large testis, large ears. First question, these are the 5 options. First question, most characteristic feature of Fragile X syndrome. 1 2 3 4 5. Most characteristic, large testis, that is macroorchidism. Most characteristic feature of Fragile X syndrome, macroorchidism. This macroorchidism, it is detected at neonate, infancy, children, puberty. कब detect होगी? It is detected at puberty. Next point, again put a double star. Clinically, what is not large? Clinically, which part of the face is not large? Nose. Not large, nose. So just touch your nose once and you will forever know that which part of the face is not large. That is the nose. Next point. So this finishes your second non-Mendelian inheritance, that is trinucleotide repeat diseases. The main trinucleotide repeat disease was Fragile X syndrome. We have seen 2 non-Mendelian inheritances till now. First was genomic imprinting, next is trinucleotide repeat disease. Next, this gets us to our next non-Mendelian inheritance, that is mitochondrial inheritance. This gets us to our next non-Mendelian inheritance, that is mitochondrial inheritance. First point, you very well know that we inherit mitochondria from the mother. So mitochondrial inheritance is maternal in nature. That is, it is maternal inheritance, meaning it has a simple pedigree chart. If the mother is affected, all the kids are affected, because we get the mitochondria only from the mother. So if the mother is affected, all the kids are affected, versus if the father is affected, none of the kids are affected. This is mitochondrial inheritance. I need not even tell you this, that round circle is female, square is male. Mother is affected, all the kids are affected. Father is affected, none of the kids are affected. It is maternal inheritance. First point. Next point. Now I can safely say that DNA is of two types. I can safely say that DNA दो type का है. DNA is of two types. That is nuclear DNA. It is of two types. Nuclear DNA and mitochondrial DNA. वो दो type का है. Nuclear and mitochondrial. Which is more predisposed to mutations? किसमें ज़्यादा mutations होती है? Nuclear की mitochondrial? Mitochondrial DNA. Mitochondrial DNA. This is more predisposed. To mutations. Why? There are two reasons for the same. Firstly, DNA repair genes. DNA repair genes are absent. DNA repair genes are absent in mitochondrial DNA. That means if a mutation has occurred, it will be persisting. It will not get corrected. DNA repair genes are absent in mitochondrial DNA. First point. And secondly, mitochondrial DNA, it is closer to oxidative phosphorylation. Mitochondrial DNA, it is closer to oxidative phosphorylation. Oxidative phosphorylation takes place in mitochondria. If this oxidative phosphorylation, if it is partial in nature, अगर partial oxidative phosphorylation है, तो it leads to the generation of free radicals. We will do the concept of free radicals when we study immunity. If it is partial oxidative phosphorylation, it leads to generation of free radicals. Which free radical is generated? Hydroxyl free radical, that is OH minus. It leads to generation of hydroxyl free radical, which in turn causes mutations. So two reasons why mitochondrial DNA is more predisposed to mutations. The DNA repair genes are absent and it is closer to oxidative phosphorylation, that is it is associated with free radical formation. So what we have seen is more mutations occur in mitochondrial DNA. First point. Next point. How many mitochondria are present in a cell? Suppose हमारा कोई cell है, we have any cell of the body. Do we have a single mitochondria या multiple? We have multiple mitochondria. It actually depends on the activity of the cell. If this is the nucleus, we have multiple mitochondria. If it is a very active cell, it will have 100 to 1000 mitochondria. Less active will have 10 to 100. Next, which was more predisposed to mutations? Mitochondrial DNA. So in all of us, we have mutated mitochondrial DNA. Mutated mitochondrial DNA present along with normal. We have mutated present along with normal mitochondrial DNA. Mutated along with normal mitochondrial DNA. In a healthy individual. That is, there is mutated mitochondrial DNA along with normal in a healthy individual. This principle is called as heteroplasmy. So what is heteroplasmy? It is the presence of mutated mitochondrial DNA along with normal in a healthy individual. तो mutated क्यों present था? क्योंकि mitochondrial DNA में mutations which were occurring were more. So this gets us to the obvious question, हम सब में mutated mitochondrial DNA है, then why are we not diseased? This is because of threshold effect. This is because of the threshold effect. Because of threshold effect. Threshold effect. This is the minimum percentage. This is the basic minimum threshold. This is the minimum percentage of mitochondrial DNA. Minimum percentage of mitochondrial DNA that needs to be mutated. Minimum percentage that needs to be mutated for the disease to manifest itself. Minimum percentage that needs to be mutated for the disease to manifest itself. That is called as threshold effect. So mitochondrial inheritance follows two principles, heteroplasmy and threshold effect. Heteroplasmy and threshold effect. It was maternal in inheritance, वो तो सबको पता ही था. Next point. This gets us to the diseases associated with mitochondrial inheritance. Diseases associated. This gets us to the diseases associated with mitochondrial inheritance. First point, I know this list will be totally new for you bache, and the details are not asked from this, but you need to know the diseases and the full forms with mitochondrial inheritance. You get simple questions. This disease, all of the following are features except, firstly something like that, or all of the following are mitochondrial inheritance except. These are the two set of questions that you get from this table, but this is important. Diseases with mitochondrial inheritance. First point, the most common disease associated with mitochondrial inheritance is MELAS, which stands for mitochondrial encephalopathy. MELAS, that is mitochondrial encephalopathy. Lactic acidosis and stroke-like symptoms. MELAS, mitochondrial encephalopathy, lactic acidosis and stroke-like symptoms. ऐसा क्यों हो रहा है? देखो, if mitochondria is not functioning well, if it is a mitochondrial disease, what is the role of mitochondria? Generation of ATP. If ATP generation reduces, it will lead to lactic acidosis. The more active muscles will be affected, that is muscles around the eye, they will be affected, extraocular muscles will be affected, and it will cause stroke-like symptoms. So mitochondrial encephalopathy, lactic acidosis and stroke-like symptoms, MELAS. Next disease associated with mitochondrial inheritance is Pearson's syndrome. Next is Pearson's syndrome. Pearson's syndrome, this is associated with pancytopenia. Pearson's syndrome, it is associated with pancytopenia, pancreatic insufficiency and lactic acidosis. Pearson's, it is associated with pancytopenia, pancreatic insufficiency and lactic acidosis. Pearson's syndrome. Next disease with mitochondrial inheritance is LHON, that is Leber's hereditary. LHON, that is Leber's hereditary optic neuropathy. Leber's hereditary optic neuropathy. LHON, meaning again it is a optic neuropathy because the muscles around the eye are getting affected. LHON, Leber's hereditary optic neuropathy. Not interested in the details, this much is sufficient. Next disease with mitochondrial inheritance is KSS. Once you read this table once or twice, you will be comfortable with it. Next, KSS, that is Keene-Sidey syndrome. KSS, Keene-Sidey syndrome. Next with mitochondrial inheritance is MURF, that is myoclonic epilepsy. MRF, myoclonic epilepsy, ragged red fibers. Myoclonic epilepsy, ragged red fibers. Throughout your 5.5 or 6 years of course bache, you would have never studied any of these diseases anywhere. They are not needed except in this table. These are the diseases with mitochondrial inheritance. Next disease with mitochondrial inheritance is CPEO. CPEO, that is chronic progressive. CPEO, that is chronic progressive external ophthalmoplegia. CPEO, chronic progressive external ophthalmoplegia. Chronic progressive external ophthalmoplegia, CPEO. These are the diseases with mitochondrial inheritance. They were MELAS, mitochondrial encephalopathy, lactic acidosis, stroke-like symptoms, PSN syndrome, pancytopenia, pancreatic insufficiency and lactic acidosis, LHON, Leber's hereditary neuropathy, LHON, KSS, Keene-Sidey syndrome, KSS, MRF, myoclonic epilepsy, ragged red fibers, MRF, and the last is CPEO, chronic progressive external ophthalmoplegia, CPEO. Done. This finishes mitochondrial inheritance. This finishes your first main topic in genetics, non-Mendelian inheritance. It was of 3 types: genomic imprinting, trinucleotide repeats, and mitochondrial inheritance. It was of 3 types. Next, this gets us to our next main topic in genetics, that is chromosomal abnormalities. Let us have a look at this in this session only. This gets us to chromosomal abnormalities. Chromosomal abnormalities. First point, I can divide the chromosomal abnormalities into 2 types, that is into number or structure of chromosomes. I can divide chromosomal abnormalities into 2 main categories: abnormalities on the basis of number or structure of chromosomes. Starting with chromosomal abnormalities in number. Achha, before I go further, tell me extreme basics. What is the investigation of choice? Investigation of choice for detection of chromosomal abnormalities. Investigation of choice for detection of chromosomal abnormalities. Answer bache, you know this. Investigation of choice for chromosomal abnormalities, it is karyotyping. Investigation of choice, karyotyping or conventional cytogenetics. Investigation of choices, karyotyping or conventional cytogenetics. All of you would have seen those 22 pairs of chromosomes, 1x 1y, that is karyotyping or conventional cytogenetics. From 11th 12th class bio, you know that karyotyping or conventional cytogenetics, in this the chromosomes are arrested at metaphase. The chromosomes, they are arrested, the growth is arrested at metaphase. And which chemical or which drug is used? Colchicine. Which drug we use? Colchicine to arrest the mitosis at metaphase. That is conventional cytogenetics or karyotyping. Next point, again starting with extreme basics. Chromosomal abnormalities on number. Investigation of choice was karyotyping or cytogenetics. I can divide the number abnormalities into 2 types. That is, it can either be euploidy or aneuploidy. I can divide the chromosomal abnormalities in number into 2 types: euploidy or aneuploidy. Euploidy is abnormality in number of chromosomes. Abnormality in number of chromosomes in multiples of n. What do we mean by multiples of n? N is the haploid number of chromosomes. N, which is the haploid number, that is 23. N is the haploid number 23. What is normal? Normal is 2N, that is we have 46 chromosomes, that is normal. Abnormality number, euploidy, is in multiples of N, that is 3N or 4N, that is euploidy. Versus aneuploidy, where abnormality number of chromosomes, abnormality number is not in multiples of N, where abnormality number of chromosomes is not in multiples of N. That is examples 2N plus 1, 2N plus 1 or 2N minus 1. 2N plus 1 is called as triplet, 2N plus 1 is called as trisomy, versus 2N minus 1, that is monosomy. 2N minus 1, that is monosomy. So abnormalities in chromosome number can either be in multiples of N or not in multiples. In multiples of N is euploidy, not in multiples of N is called as aneuploidy. Next point, let us first start with trisomies. Starting with the first main disease associated with abnormalities in multiple of chromosomes, that is Down syndrome. Let us start with the first one. That is Down syndrome. That is Downs. What is Downs? Down syndrome, it is trisomy 21. I need not even say this, it is trisomy 21. Put a line on the side. Trisomy 18 is called as Edwards syndrome. Trisomy 18 is Edwards syndrome, versus trisomy 13, which is called as Patau's syndrome. Patau, it has a T in it. 13, Patau's syndrome. Down syndrome, trisomy 21. So let us come back to Downs. Extremely important. Starting with Down syndrome, trisomy 21. क्यों हो रहा है? What is the mechanism of Down syndrome? The most common mechanism is it occurs because of maternal meiotic non-disjunction. Very important to understand. Maternal meiotic non-disjunction, which is this was this year's June PJ exam question also. Maternal meiotic non-disjunction के कारण हो रहा है. What does this mean? देखो, you know that meiosis में diploid number 2n becomes n. In Downs, mother का chromosome 21, maternal meiotic, there is non-disjunction of chromosome 21, meaning of the mother both the chromosome 21s came to the child, of the father एक आया, तो it is trisomy 21, maternal meiotic non-disjunction of chromosome 21, which is the most common cause of Downs, accounting for approximately 95% cases of Down syndrome. First point. Next point. What is the main risk factor? For Downs to occur? Main risk factor: alcohol, smoking, increased age, multiparity. What is the main risk factor? It is increased age of the mother. Main risk factor for Down syndrome, increased age of the mother. First point. So this is the most common mechanism of having Downs. Next, Downs can also occur because of paternal non-disjunction of chromosome 21. It can also occur because of paternal non-disjunction, but it is rare. And the third cause of Down syndrome, put a double star. It occurs because of translocation. Which type of translocation? We will do translocations in detail when we do chromosomal abnormalities in structure. We'll be doing that in our next session in genetics only. But which translocation? we will see that there is a particular subtype of translocation called as Robertsonian translocation. अभी सिर्फ लिख लेते हैं, we will do this in detail in our next session. Robertsonian translocation of chromosome 1421. Just write it at present. Out of these, most common mechanism was one, maternal meiotic non-disjunction of chromosome 21. Next point, Down syndrome. Clinically, Down syndrome clinically is the most common genetic cause. It is the most common genetic cause of mental retardation. You already know that. It is the most common genetic cause of mental retardation. Next point, it is associated with flat epicanthal folds, also associated with the presence of simian crease. Simian creases, they are present in the palms of the hand. Simian creases. Coming to the more important points, put a star. It is associated with umbilical hernia. Very, very important. पूछा जाता है. Umbilical hernia is associated with umbilical hernia. Congenital CVS abnormalities. So first question, which is the most common CVS abnormality in Downs? Most common CVS abnormalities in Downs. Endocardial quotient defect, ventricular septal defect, atrial septal defect, which one? Most common CVS abnormality in Downs is endocardial quotient defects. Again, a commonly asked question in which students go wrong. Endocardial quotient defects. This is the most common CVS abnormality in Down syndrome, followed by ventricular septal defects, followed by VSD, ventricular septal defects, followed by atrial septal defects. So Downs is associated with CVS abnormalities. Most common is endocardial quotient defect, followed by ventricular septal defects, followed by atrial septal defects, CVS abnormalities. Next, Down syndrome is also associated with intestinal obstruction. In the GIT, it is associated with intestinal obstruction, where the most common site of intestinal obstruction. GIT में intestinal obstruction कहाँ हो रही है? Duodenum, jejunum, ileum, colon, कहाँ पे? Duodenum में. Most common site being duodenum. That is, it is associated with duodenal atresia. Most common site of intestinal obstruction in Downs being duodenal atresia. Next point, Down syndrome is associated with increased risk of leukemias. It is associated with increased risk of blood cancer or leukemias. Again पूछा जाता है, most common leukemia associated with Down syndrome. Answer बच्चे, most common leukemia associated with Downs. Answer. देखो, have a look at the question. Most common leukemia with Downs is ALL, acute lymphoblastic leukemia. Most common leukemia with Downs, ALL, acute lymphoblastic leukemia. But the most common AML with Downs, that is most common subtype of acute myeloid leukemia with Downs, is AML M7. Have a look at the difference in question. Overall, most common leukemia in Downs is ALL, acute lymphoblastic leukemia. लेकिन most common AML in Downs is AML M7, which is acute megakaryocytic leukemia, AML M7. Last point, most common leukemia in Downs most common leukemia in Downs in less than 3 years of age. In less than 3 years is again AML M7. So have a good look at what the examiner is asking you. Overall, most common leukemia was ALL. Most common AML was AML M7. But in less than 3 years of age, most common acute leukemia is also AML M7. This is Down syndrome. The lower 4 points are asked. Downs is associated with umbilical hernia, CVS abnormalities, most common being endocardial cushion defect, intestinal obstruction, that is duodenal atresia, and is associated with increased risk of leukemias. These are the clinical features associated with Down syndrome. Next point. This gets us to antenatal diagnosis. This gets us to the antenatal diagnosis of Down syndrome. Antenatal diagnosis means antenatal diagnosis of Down syndrome. That is, even when the child is in the womb of the mother, बच्चा इंट्रायूट्राइन है, he is not born yet, इंट्रायूट्राइन है, पैदा होने से पहले, antenatal diagnosis of Downs. There are two ways to do it, radiologically and serologically. Starting with radiology, there are numerous signs associated with Down syndrome. Not concerned. What I am primarily concerned is Downs is associated with increased nuchal fold thickness. Down syndrome is associated with increased nuchal fold thickness. What is nuchal fold? Nuchal fold, it is the thickness of the skin of the neck. That is the space between the spine and subcutaneous tissue of the skin of the neck. इतना details जरूरी नहीं है, मोटा सोचो, thickness of skin of the neck is increased in intrauterine life in Downs. Increased nuchal fold thickness. Next, versus serologically, extremely important. Serologically, we look at two markers, or let me rephrase, we look at two types of tests: the triple screening of Downs and the quadruple screening. Let us start with triple screening. Of Down syndrome. Triple screening, we look at three markers. AFP, that is alpha fetoprotein. We look at three markers in Downs: AFP, alpha fetoprotein; beta HCG, that is beta human chorionic gonadotropin, beta HCG, and UE3, that is unconjugated estriol. UE3, that is unconjugated estriol. We look at three markers. Triple screening: AFP, alpha fetoprotein; beta HCG, unconjugated estriol. In Down syndrome, AFP reduces. Very, very important, extremely important. Beta HCG increases, whereas unconjugated estriol also reduces. Though all 3 points are asked, but AFP reduces in Downs is very, very important. Which is the main tumor in which AFP increases? We will see that when we do neoplasia in general pathology. But bache, alpha fetoprotein, AFP, is increased in which tumor? HCC, hepatocellular carcinoma. It is increased in HCC. AFP reduces in Down syndrome. Next, this was triple screening of Downs. Next is quadruple screening. Quadruple screening of Down syndrome, जिसमें we add another marker is added in quadruple screening of Downs, that is inhibin A. We add inhibin A increases in Downs. So quadruple screening में दो increase होते हैं, beta HCG and inhibin A increases, AFP and unconjugated estriol reduces. This is Down syndrome. This was your main disease associated with abnormalities in chromosome number, abnormalities in chromosome with number of chromosomes, that is trisomy 21 Down syndrome. Next, this gets us to our next disease in chromosomal abnormality with number, that is Turner's syndrome. This gets us to our next disease in abnormality in number of chromosomes, that is Turner's syndrome. First point, starting with Turner's, I am sure you know this. Turner's syndrome, it is 45 XO. What is Turner's syndrome? This is 45 XO. देखो, this is important. We always write the total number of chromosomes, sex chromosome. इसको never write it as 44 plus XO. This will be wrong. Total number of chromosomes 45 में देखो, normally 46 होते हैं, 46 XX या 46 XY, that is normal. Total number of chromosomes 45, क्योंकि एक सेक्स क्रोमोसोम कम हो गया ना, 45 XO. So in Turner's syndrome, female is XX. In Turner's, one X is missing. So clinically, it is the secondary female sexual characteristics. Clinically, secondary female sexual characteristics are reduced. क्योंकि female should be XX, एक X missing था. Secondary female sexual characteristics are reduced. So think of your favorite girl and imagine opposite of her, that is Turner's. So the patient has a low stature. The patient has a short stature. Next, low webbed neck, or a short low webbed neck, that is neck की लंबाई कम है, मोटी है, low webbed neck, widely spaced nipples, streak ovaries, streak ovaries means there is fibrosis occurring in the ovary. Streak ovaries, why is fibrosis occurring? क्योंकि एक X chromosome कम है. Streak ovaries, cubitus valgus, streak ovaries, cubitus valgus. What is cubitus valgus? The angle between the upper arm and the forearm is increased. Cubitus valgus and peripheral lymphedema. Cubitus valgus and peripheral lymphedema at birth. This is Turner's syndrome. Peripheral lymphedema at birth. Let us see the questions associated. ये सारे पॉइंट तो ऑब्वियस थे if you just knew that the secondary female sexual characteristics are reduced. Let us see the questions. First question, Turner's syndrome, it is not associated with umbilical hernia. Turner's is not associated with umbilical hernia. Umbilical hernia is a feature of Down syndrome, not Turner's. It is not associated with umbilical hernia. First point. Next point, FSH and LH in Turner's, low, normal, high. Think of it yourself. FSH and LH, low, normal, high. FSH and LH is high. Why? Because Turner's is associated with streak ovaries. So hypothalamic pituitary axis is trying to stimulate the ovaries. So FSH and LH is high. Next point, because of streak ovaries, it is associated with amenorrhea. Amenorrhea means the girl is not bleeding. It is associated with amenorrhea. ये कौन सा amenorrhea है? Primary amenorrhea कि secondary amenorrhea? Is it primary or secondary? Primary amenorrhea. Primary amenorrhea means the girl has never bled. Secondary amenorrhea means the girl was bleeding लेकिन अब बंद हुआ है. So the girl never bled because of streak ovaries. It is associated with primary amenorrhea. Next question, IQ, low, normal, high. देखो, from our day-to-day activities, especially the guys, we know more are the number of X chromosomes, low is the IQ. Notable meanings, girls don't get offended, just easy to remember. More the number of X chromosomes, lower is the IQ. Turner's is XO, इसमें एक X कम है, so IQ low, normal, high. IQ is normal. High IQ नहीं होगी, she will not be an Einstein. IQ is normal. This is Turner's syndrome. This is Turner's. Next point. Next and the last disease in chromosomal abnormality with number. I know this was a slightly long session, but last disease in chromosomal abnormality with number. That is, this gets us opposite of Turner's. That is Klinefelter's syndrome. This gets us to Klinefelter's syndrome. Klinefelter's syndrome. What is Klinefelter's? Normally, I hear the answer as 47XXY. Fair enough. But a better way of saying it is Klinefelter's. It is more than one X chromosome. More than one X chromosome with at least one Y chromosome. More than one X chromosome with at least one Y chromosome. With most common Klinefelter's being 47XXY. Most common being 47XXY. But rarely it can be 48XXY or 49/4XY also, though this is rare. More than one X chromosome with at least one Y chromosome. So, clinical features of Klinefelter's. Obvious है. बच्चे मेल इज 46XY, इस मेल में एक X बढ़ गया. So clinically the secondary male sexual characteristics are reduced. As a result, the patient has a unicoid body habitus. Unicoid body habitus मतलब all of you would have seen eunuchs. Male, female, and the third sex. The third sex is unicoid body habitus. That is, the patient is tall with female-like. The patient is tall with female-like facial hair, tone of voice, female-like facial hair, tone of voice, and pubic hair distribution. With female-like facial hair, tone of voice, and pubic hair distribution. This is Klinefelter's. So let us see the questions with this. First question, Klinefelter's syndrome. FSH and LH. Low, normal, high. देखो, what was Klinefelter's? It had more than one X chromosome with at least one Y chromosome. तो X chromosome बढ़ रहा है. So FSH and LH high. As a result, obviously, estrogen to testosterone ratio increases. X बढ़ गया ना. Male was 46XY, इसमें एक X बढ़ गया, तो estrogen to testosterone ratio increases, estrogen बढ़ जाएगा. As a result, Klinefelter's is associated with gynecomastia. It is associated with enlarged male breast. That is, it is associated with gynecomastia. Next point, IQ. Low, normal, high. जितना ज़्यादा X chromosome होगा उतना low IQ होगा. So IQ is low. But in majority of cases, Klinefelter's is not associated with mental retardation. This point is again important, बच्चे. देखो, which was the most common Klinefelter's? Majority, most common was 47XXY. 47XXY is low IQ. It is not mental retardation. You will do this in psychiatry. IQ less than 70 is mental retardation. 47XXY is low IQ. It is not mental retardation. As the number of X chromosomes increase, 48XXY or 49/4XY, this can be associated with mental retardation. This can be associated with mental retardation, but this is not common. But this is not common. Common क्या था? 47xxy. So it is associated with low IQ, but mental retardation is uncommon. Done. This finishes chromosomal abnormalities in number of chromosomes. So what did we do in our first session of genetics? We started with point mutations. We divided genetic diseases into three categories: Mendelian inheritance, non-Mendelian, and chromosomal abnormalities. We have finished non-Mendelian inheritance, three types: genomic imprinting, trinucleotide repeats, and mitochondrial inheritance. We have done this. After that, we came to chromosomal abnormalities. They can either be number of chromosomes or structure. We are done with chromosomal abnormalities and number of chromosomes.